So after going through the microscopic picture of the choriocarcinoma, let's see how does the tumor spread to the various organs of the body. It can either spread to the adjacent organ like parametrium by the direct spread, or can have a hematogenous spread, and hematogenous spread occurs quite early to distal organs in choriocarcinoma. The commonest site being lungs, in 80% of the cases it is seen. The other organs are vagina, 30%, brain, 10%, and liver, 10%. To a lesser extent, it can also go to the spread to spleen, kidney, and GI tract. And even if it is spread too much, then any organ of the body can be affected by it. And thecal lutein cysts of the ovary are found in about 9% of cases of choriocarcinoma. So how does a choriocarcinoma present? The most common presentation is persistent or irregular vaginal bleeding. The commonest symptom occurring after labor, abortion or evacuation of a vesicular mole. It can occur after a few months, days, or but rarely it can even occur after 2 years after these events. The other common presentation is vaginal discharge, which is usually blood-stained and offensive due to ulceration and infection of the growth. Due to the high levels of the HCG, amenorrhea also may be present in these cases, and because of the enlarged uterus or enlarged ovarian cysts, pelvic pain or pressure may be another symptom. So what can be the clinical features due to metastasis? If there is a lung metastasis, which is the commonest metastasis in choriocarcinoma, the patient can present with dyspnea, cough, chest pain, and hemoptysis. If it is a vaginal metastasis, patient can present as irregular and at times brisk hemorrhage. In cases of brain metastasis, there can be neurological symptoms like hemiplegia, seizures, headache, dizziness, and visual disturbances. And epigastric pain and jaundice can be present in cases of liver metastasis. So this choriocarcinoma has got a very rapid growth and widespread dissemination quite early in the course of the disease, and there is a high propensity for hemorrhage, so that sometimes makes this tumor as a medical emergency. So how do we do clinical evaluation in cases of choriocarcinoma? So when this is diagnosed on the basis of very high level of the human chorionic gonadotrophin, following a molar pregnancy, the patient should be evaluated to determine the extent of this disease, are there any metastasis present, and staging of the disease which we had dealt with earlier, and what is the risk factor scoring, which we'll be coming to later. In the history, it should focus upon the antecedent pregnancy, is it abortion, molar pregnancy, or ectopic pregnancy, or a normal pregnancy, symptoms of any which have been described earlier, and their duration and prior treatment given, if any. How do you do physical examination in these cases? On general examination, not much is seen except for some pallor. Respiratory system, there can be, you have to evaluate the respiratory rate and if there are any adventitious sounds like crepitations. But for determining any lung metastasis is there or not. In cases of for central nervous system, the level of consciousness should be assessed. Are there any focal neurological deficits or this thing? On abdominal examination, see for hepatomegaly, uterine enlargement, and if there is any tenderness. On perspicuum examination and local examination of the external genitalia, suburethral or vaginal nodules can be seen, and sometimes bleeding is also there, which may be excessive. Bimanual examination is done for the uterine size, and at times even ovarian enlargement can be made out. So the signs in these cases are uterus may be enlarged and boggy. Vaginal metastasis appears as bluish red vascular tumor which bleeds on touch. Thecal lutein cyst may be palpable in some cases. Abdominal tenderness and sometimes rebound tenderness may be present if hemiperitoneum is present. Abdominal tenderness is also present if liver or gastrointestinal metastasis have occurred. Bleeding from metastasis could also result in symptoms and signs of hemorrhagic shock. Investigation. The most important investigation is, of course, the level of the serum beta HCG. It is the first step when the disease is detected. Persisting or rising titers in absence of pregnancy indicate trophoblastic neoplasia. It produces abundant amounts of human gonadotrophin. The range can be from as low as 100 to over more than 1 lakh milli-international units per ml, depending on the extent of the disease. Pre-treatment value is of prognostic significance. A metastatic brain lesion is suspected when the beta-HCG in spinal fluid to serum ratio is more than 1:60. And always the baseline beta-HCG level should be documented. Other laboratory studies which are not diagnostic but should be done include complete blood count, which may help to detect anemia secondary to bleeding. In cases of liver metastasis, liver enzymes may be elevated. A thyroid function test and important should be ordered if the HCG level is more than 1 lakh milli-international units per ml to determine if the patient is hyperthyroid. So, imaging studies are important in cases of choriocarcinoma. The ultrasound of the lower abdomen, you see uterine lesion can be detected and often appears as a mass enlarging the uterus, and sometimes it manifests as a discrete central infiltrative mass. Sometimes this carcinoma and invasive moles are very vascular, and the tumor may be seen infiltrating the myometrium. Chest X-rays should be done in all the cases of GTN, and it used for diagnosis and counting the number of pulmonary metastases. It can be in the form of snowstorm pattern, discrete rounded densities, pleural effusion, or pulmonary artery occlusion by emboli. The most common forms are cannonballs or snowstorm appearance. So in 40 to 45% cases of gestational trophoblastic neoplasia, X-ray chest may be normal, but however CT chest may show evidence of micrometastasis. So the next important investigation in the imaging study is computed tomography. It may be useful for lungs, liver, brain and bone metastasis. And abdominal, it is helpful in evaluating the abdominal and hepatic lesions. And this patient later on, these are the hypointense lesions which are seen, and this led to the rupture of the liver in this case. The magnetic resonance imaging along with the CT can be used for the diagnosis of brain metastasis. So positron emission tomography is useful when either MRI or CT do not reveal metastasis, but beta HCG is elevated. So endometrial curettage is one of the diagnostic features of choriocarcinoma. It's mainly done for the histological diagnosis, but usually this is not required for initiation of treatment. However, invasive mole cannot be diagnosed by doing the endometrial curettage, and curettage is associated with high risk of perforation and hemorrhage, which in some cases may necessitate emergency hysterectomy. These investigations may be required for diagnosis of placental persistent cytotrophoblastic tumor and epithelioid trophoblastic tumor. Women who present with symptoms suggestive of GTN and with low HCG levels, these should be suspected and the curettage in them should be performed. High index of suspicion is necessary to make a diagnosis. If you are doing pre-therapy DNC, this reduces the intrauterine tumor bulk. So diagnosis of metastasis by clinical examination and by investigation. Vaginal nodules can be diagnosed by the excision biopsy, or in some cases biopsy should not be done because it may lead to massive hemorrhage following resection, which may need packing or sometimes even selective embolization. So you should be careful while doing the excision biopsy of vaginal nodules. So in cases of cerebral metastasis, the ratio of the HCG levels in the spinal fluid and serum is higher than 60. CT scan or MRI is also helpful in diagnosing the brain metastasis. For liver metastasis, it is CT scan and ultrasonography. Chest X-ray can be done, and CT may show micrometastasis which may not be visible on chest X-ray. This happened about 40 to 50% cases of micrometastasis. Metastasis to other sites are uncommon when pelvic examination and chest X-ray are normal.